And we're back with Dr. Craig Walker. We continue about critical limb ischemia. Let's talk about diagnosis a little bit. How do you go about doing all that?
Sure. Well, when a patient comes in and has any of these problems, we first examine the patient. A lot of things we're looking for. We're looking to see the character of the pulses, if they're present or not. If they have an ulcer, is there evidence of infection? Or if there's gangrenous changes, how deep is it? We can measure pressures in the feet and just see how diminished these pressures are. We can use ultrasound to look at the flow of blood. And on the high end, we can do CT angiography done in the office, just an IV, not even an arterial stick. We can give contrast and actually get a picture of all the blood vessels from the diaphragm all the way to the feet. Or we can actually go all the way to doing an angiogram in the hospital, wherein we do stick an artery, we inject dye, and we make images. Now, each of those has its pros and cons. We can, with a real angiogram, there's a little bit more risk. You have to go into an artery so you can bleed, but we can subtract out all calcium, and so we can see some things you could not see from some of these other tests. But with these tests, you can absolutely, in everyone, determine what's going on. You know, the sad part is the overwhelming majority of Americans with critical limb ischemia are simply not diagnosed. Less than half even have a pressure measured in their feet, and less than 20% get an angiogram. They simply go straight from having an ulcer to having an amputation, and that's simply wrong, because the overwhelming majority, more than 97% of those people with today's techniques can achieve limb salvage. Just today I had a patient sent down from Idaho that had been through 5 different hospitals where people had tried different things and had failed, and he was scheduled for bilateral leg amputations. And really, with a fairly short procedure, he ended up with pulses in both feet. And I think, you know, this speaks volumes of where this field is going. In the overwhelming majority of patients, there's a lot that can be done.
Now, what about treatments and all? Is that where the treatments, how many treatments are there?
There are a lot of treatments. Obviously, from the get-go, we have medications, and the medications include things to improve blood flow, to block spasm, to help people get off of cigarette smoking, because cigarette smoking is clearly a no-no, to better improve diabetes control, and to stop blood from clotting, because clotting is a no-no when people have critical limb ischemia. All of those things are very important. In addition to those issues, if a person has infection going on, we have to clear up infection. And so antibiotics become a critical part of what we do, because we certainly must do that. If we get blood supply to an area but there's an infection that gets into the bone, then we really haven't done a lot of good. So that becomes very important. We have to do wound care. We have to be able to clean out dead tissue and get down to live tissues. We have to be able to do skin grafting once we have good blood supply. So all of these things play a role, but really the nuts and the bolts of getting these people to improve is to improve blood flow to the area. I mean, everything else really is dependent and hinges on better blood flow to the area, because that was the base cause of the problem in the first place. And so improving blood flow makes a difference. And we have a whole armamentarium of tools now that we can use. Of course, there's still surgical techniques. We can do a bypass. And I don't want to leave out the fact that bypass has improved a lot from where it used to be. There are a lot of surgeries now that have really improved technique to the point that surgeons can really bypass all the way down to the top of the foot in patients, and this can be limb saving. But where I think there's just been an unbelievable growth is in the ability to interventionally open blood vessels. And with that, we have a lot of new tools. One, we have drugs that allow us to dissolve clots. We have balloons, which have gotten better. You know, we think about a balloon and we go, I just one balloon. Well, it's not the case. We now have longer balloons. We have balloons that freeze tissues.
Come a long way with those during
Oh, for sure. We have balloons in Europe right now that actually give off drugs, and these drugs may stop a blockage from coming back. And I think it's only a matter of time before we have those in America. We have atherectomy tools. We have laser, Fox Hollow. Athromed's Phoenix device, which we just recently did the first case in America with. We have Pathways, we have CSI. These are all tools that we can actually go in and remove the plaque in some way, shape, or form to create a channel. We have stents, and there are a whole myriad of stents which are out. Some are some have drugs affixed to them, some do not. Some are covered with tissue, like a bypass graft. Some are just simply bare metal. There has been an unbelievable advance in these stents. These stents used to not be very flexible. They used to not have great force. All of that has changed. And so now we have, in terms of stenting, 4 more options. And so in terms of what is available on the interventional side, it's really a toolbox that just is growing every single day. And
You have a heck of a lot of options, and I wanted to ask you also, you went to China recently. You've been going to a lot of different places. And in China, from what I understand, they had the most critical patients that were about to lose limbs or whatever. They put you on 10 cases. You saved 10 legs or limbs.
What they do is they ask some of the visiting professors who are doing, and I was asked to be the physician doing live cases. And we're given pretty tough cases to do. These were all people who had very critical blockages, and we didn't always have all of the tools that we're used to using. There were fewer tools available to
China's
us.
supposed to be so advanced, but really, we're a lot more advanced in some techniques.
Yeah, I would say in medicine we clearly are, but China is certainly coming on strong. I was impressed by what I saw. I was impressed by their willingness to learn. I think that's always the first and most important thing, is open minds in terms of getting people to do better. But we had a huge audience there, well over 20,000 cardiologists and vascular surgeons watching, and we had these very difficult cases that had been tried and failed, and we were pretty lucky. We got all of them, and things went very well with that. Now, I think, though, that it speaks loudly about how far this field has come, because certainly 10 years ago, taking on those kinds of cases, you wouldn't expect to get all of them. Half would have been considered a great win. And yet now, when we don't succeed, I go home depressed, frankly. I mean, it's gotten to the point
But
that...
I've seen your determination before.
I mean, it's really gotten to the point that we really do succeed in almost all of these cases, even the toughest of tough. And not all. I wish we would get to that point, and that's always my goal, as you well know. I mean, we don't give up too easily.
But y'all had a first today. I got a press release, and I'm going to give you a little chance to talk about it. Y'all did something that's never been done before. What exactly was it?
Well, it was not done in the United States. It had been done overseas. We used a new form of atherectomy tool, which is made by a company named Athromed. It's the Phoenix Athromed tool. And it's got several unique properties. It's an end-hole cutter that actually has sort of an Archimedean screw that removes tissue, and so it's less likely for this tissue to break off and go downstream and injure anything. And so in particular, in small vessels, this makes for a very, very clean channel, a very smooth, nice bore channel. And at least in this case where we used it, it was, as I said, the first case done with this device in America. We ended up with a spectacularly nice channel and a very nice distal pulse. So we're encouraged by that. But you always have to temper your enthusiasm, because only after we do enough of these cases and follow them are we going to know exactly what role this device will play. We were very enthused early on about stents, and they proved to be right. We were enthused about some other things in the past, and they weren't. But the only way that science and medical science can move forward is you have to try new things. If you don't, by definition, you can't move forward. And by having these things and making sure that we're very careful with them, and we don't just simply use them in everyone. We had screened 15 people that we were considering, and we used it in one. And the reason for that, we want to make sure that that we only do this in cases where we'd want it used in ourselves when we do this.
We were just talking with Ann offset, and of course, you agree we're going to bring you on with some devices one night. We're actually going to show some of these cases, right?
Sure, that'd be fun. I'd love to do that.
But we always appreciate you coming on, and thank you so much for what you do, and keep up the good work.
Thank you, Mark.
Keep them straight in China and Japan and all that over there.
I enjoy coming here a lot more. Thank you.
Thank you. All right, we'll take a break. When we come back, we're going in the kitchen with Chef George. The Canada's Kitchen, and Harry McCullough will be on hand. He'll bring you there when we come back. Don't go away.